invite Dr. Kumar Doctor to present his paper on Toric marker for lenticule-based refractive surgery.
No, that's not the one. That's not the one. Toric.
Fourth presentation.
394. 394. Below that.
The toric marker for lenticule-based refractive.
Yeah. Thank you. Good morning, everybody, and thank you for adjusting the time as I have to run to another hall. I would like to thank Dr. Shivani who helped me to compile this. So what we have done here is we have invented a toric marker specially for lenticule surgery, which marks 0, 90, and 180, and there's a reason why we did this. As we know that all the marks which are there, it all depends on the system that we have. So I have a Z8, no financial interest. It's very important that we mark the cylindrical eyes, whichever have a cylindrical number. But I also decided that we have to mark all the eyes which also have a spherical error. And there's a reason why we did this. And the purpose of this whole idea was to make sure that we get perfect results as far as centration is concerned the next day. So we had 50 patients in a setting where we took myopic eyes of minus 0.75 CIL and above, and the highest limit being minus 5. So you can see on the right side that there is a toric marker. The difference here is that it is a modified AIOC marker. I've removed the center ring so that we can look at the patient looking at the light, and so you got your visual axis. And I'm marking 0 and 90 on a Virion image-guided technology. So what's happening here is the marker length is long because on my technology, what we have, the marker, the camera situation is in such a way that the marks can be seen only in the center. So this is very, very important. Otherwise, if this is not visualized, because if we have toric IOL markings, they are on the periphery. But in this, we need them in the center, and that's the reason why I modified the marker. And that I got it right into the center. And all the surgeries were performed by me as far as the lenticule extraction is concerned. So all of them were done on the Z8, and we call it clear. It's corneal lenticule extraction for advanced refractive correction. And you can see on the right side, the marker is got a central circle so the patient can fixate the light of the microscope. So you got your visual axis. And the 3-prong marker is 90 and 180, which is done. And once the marking is done, we take the patient onto the femto system. And then after that, we make 1 drop of methylene blue because that highlights the mark which is there. And once that is done, we go ahead and do the lenticule extraction. So the whole system goes like this. So as far as you can see that the results are there, we can see the topography here, which is a very well-centered ablation. The advantage here is from day 1 to day 7, all of them become 6 by 6. Of course, depending on the experience that we had, now it's 2 years of experience. And post-operatively, we found excellent results as far as patient satisfaction was concerned. Thank you.
So, sir, this marker was kind of innovated by you.
Yes.
And you modified some other marker for it.
Yes.
And spherical errors, can you just explain a little more, sir?
Yeah, so what happens here is in lenticule extraction, the pressure of the eye goes up. So the pupil becomes slightly eccentric. Now, when we are doing excimer laser and we are creating a flap, the pressure still goes up in most of the systems. We are centering the flap on the pupil. So technically, in a flap-based surgery, your flap may be slightly eccentric, but you don't need to worry because your excimer laser is treating the pupil. So even if your flap is slightly decentered, it doesn't really matter because the excimer is treating the pupil. Now, as far as lenticule-based procedures are concerned, the lenticule has to be on the visual axis. So when the pupil becomes slightly eccentric, if we move the lenticule to center it on the pupil, you'll have a decentered lenticule. So what we thought was, in this system on the Z8, it automatically aligns the mark. So when we have the marks, so it's all depending on the camera in your system. So the camera angulation in flap-based surgery on the Z8 is in such a way that you can see the whole applanated area. But in lenticule extraction on the Z8, the camera angle changes, so we don't see the entire applinated area, but you see the central 8 millimeter. You don't see 10 millimeter. And that's the reason why I made these markers longer, so that it comes towards the center, point 1. So once I mark on image-guided technology, I thought it is it can't go wrong, because that's a perfect technique of marking. Once we mark, I put 1 drop of methylene blue. Once that is done, it highlights the mark, and then increase the pressure on the Z8 to make the lenticule, and don't move the lenticule onto the center of the pupil. So you don't move the trajectory on the laser to center it on the pupil, but you just align it on this mark. So it may appear completely decentered. For example, on silk or on Elita, when you look at the image, it looks completely decentered. The reason why it looks decentered is the camera angulation. It's nothing else. It's very well centered. But here, then we decided to do this even for spherical errors, because the pupil will become little eccentric moment the IOP goes up. So even in spherical errors we are marking, and in cylinder errors also we are marking, and this made sure that we never have a decentered lenticule. That was the idea of doing this.
I think it's a very good study, and also it takes care of the cyclotorsion.
Yes.
So that's very important.
Yeah. So we have gone till 2.75 SIL till now, pure SIL, and I have a cap of 120. I'm not doing 110. I've done a few cases with 110, but with 120 also it's very comfortable. Thank you. Thank you, ma'am.
Thank you, sir. We have the next presenters, Dr. Salu Chandra.